All right, we should actually get started. It's an interesting so the topic today is like immune mediated polyarthropathies and other immunological weirdness, basically. So the the reason I made that the topic is because there's a bunch of chapters like dermatologic diseases, um, autoimmune diseases, vasculitis, systemic lupus erythematosus and stuff, where the kind of principles behind it are all the same. It's sort of activation of the immune system inappropriately. It's just targeted in different places, and the therapy, therefore, is quite similar for a lot of them. So I lumped them in together because I thought we could talk about them all sort of as one. But the main one I want to focus on is IMPA because I feel like that's the one we see most commonly. Is that everybody else is happy with that? I think we have a new person here. I don't know if this person's name is actually Toby, but I will just say I tend to teach by asking questions. So I will never target you as a new person unless you identify yourself as wanting to be targeted. Pooja is fair game. Julian, I'm working on, and Jeff is definitely fair game. But yeah, if you do want to participate in the conversation, please feel free. Um, okay. So, IMPA, how do these animals present? What have you seen?
Like painful or walking on eggshells lame.
Mm, yeah, that's my experience too. I was interested to see Edinger says that 70% of dogs, no, sorry, only 70% of dogs presented with lameness when they came in with a polyarthropathy.
Interesting.
Interesting, yeah. And I guess that's sometimes because it's multiple legs affected, you've got all four legs. And sometimes it's not really a recognizable lameness, it's more the systemic illness that they're kind of presenting for. It might be the pyrexia or something. Um, what else might we see clinically? Pyrexia, I said that.
Yes, they can have an on and off history of not doing quite right. So
Mm.
or even fever, like a fever that you can't really localize to some specific sort of infectionitis.
Mm. Yeah, good. And if you were doing a clinical exam in a patient that was just kind of ain't doing right, maybe had a borderline neutrophilia, a borderline pyrexia, CRP was like 40. So they're all the kind of test results that have been accumulated. And then you're seeing this dog for the first time. What are you going to do in your examination?
Palpate the joints, but they don't always have to be like you don't have to always palpate swelling.
Yeah,
Lucky if you get it. You can do a little dance.
yeah, I agree. I find these guys quite hard to identify. So we're going to palpate the joints. What else?
Hmm.
Palpate. So palpating is kind of like,
Do you mean like range of motion to
yes, good, yeah. Um, so in which joints in particular are commonly affected with polyarthropathy, immune-mediated polyarthropathy?
Distal.
Distal, good. And what about um, degenerative polyarthropathy, like degenerative joint disease that's affecting multiple joints?
That's usually like hips and stifle.
Hips, stifles, elbows.
Elbows.
Yeah, I reckon the most common joints. But they can present very similar, and there's a very big overlap in age where we sort of expect to see degenerative changes. It's big overlap in cytologic findings, big overlap in radiographic findings, so they can be quite hard to differentiate. So it's these little clues that can help. That's maybe it's just the carpi affected or carpi and Hox, and you sort of think, okay, this is more likely immune mediated or polyarthropathy. Um, okay. So, does anyone know? Is there anything else? Oh, clinical. There's more clinical exam stuff I want to know. And I want you to think of what are the different causes of polyarthropathies and what might I need to be screening for in case it's not immune mediated.
So then type 3 is GI related. So if you have a history of like gastrointestinal problems on and off,
Great,
then
great.
maybe, or at least preceding this event, then type 3 is in the list in your head.
Yeah.
You're screening for cancer for type 4 because that's associated with neoplasia.
Yep. And so there's actually a few different um like classification systems. The system you're using, is that the one from the Andrew Macken paper? Type 1, type 2, type 3, type 4?
Yeah, yeah.
And
I
there's
don't know where it is from, but yeah, that's type 1, type 2, type 3, type 4.
there's a really good review paper. I think it was in the AVMA, the JAVMA journal, that is the most logical summary, but it's not actually the format that was followed in Edinger, which makes it a little bit confusing. But what Pooja's referring to is that there's lots of different triggers for polyarthropathies, and having a system in mind for the things that you kind of need to rule out or in is really important. So type 3 is secondary to gastrointestinal disease specifically. Type 4 is like a reactive, is that what they call it? Reactive IMPA?
As in secondary to neoplasia in the body.
Yeah. So
And
near.
type 2 is antigenic response somewhere else. So there's some infection somewhere else, and then the joints are affected. And
Okay.
type 1 is primary, your immune mediated.
Yeah. So primary immune mediated. Okay. Excellent. So it doesn't really matter what system you use, but it's really important that you've got in mind. You sort of think of like immune mediated polyarthritis, and the instant thing you think of is like there's an antibody directed at the joint or an element of the joint. And that's actually really, really, really rare. So that's not the manifestation we see most commonly. And that's the type 1 type. Whereas type 2, which is almost like a reactive arthritis, is because we've got a lot of antibody excess or antigen excess somewhere in the body. So we end up with more antibody antigen complexes forming, and they get deposited in the synovium. So most of the time, that's because you've got a distant infection or inflammatory process. Does that make sense? Cool. So we can have infectious or reactive is the way that I kind of classify them. Tell me what sort of infections can directly infect the joint or cause an infectious polyarthropathy.
Rickettsial infections are big.
They're the main ones, by far the main ones. There's an interesting syndrome of, do you guys know what L-form bacterias are?
Kind of. No, like never really seen a case, or so not like I know it as a textbook thing, but not really as a thing.
Yeah. So it's a textbook thing for sure. I've never seen a case, but it's so interesting. So there's this syndrome, particularly in cats, after cat fight abscesses. So cat fight abscesses are really notoriously, like if you don't lance it and flush it and treat it surgically, if you just treat it with oral antibiotics, the bacteria will be exposed to a certain level of antibiotics, but not enough to clear the infection most of the time. So in this syndrome that's been described, the bacteria have mutated in response to seeing antibiotics. There are other triggers as well, but they've lost their cell wall and they've just become these little blobs, which are generally circular in shape, but they don't stain with a gram stain, so they looks like a sterile infection. And they're not susceptible to any of the antibiotics which target the wall, so any of the penicillin cephalosporins. And they cause this polyarthropathy. So there's this history of a cat fight abscess and then a polyarthropathy. So it's a very specific syndrome. If we can't use the cell wall as a target without antibiotics, what classes of antibiotics could we use?
Don't. This is okay. I'm gonna stab in the deep end. Aren't fluoroquinolones targeting DNA?
Good, excellent. That's a really good choice. Yeah. Fluoroquinolones are great for what were gram negatives originally, and some of them have quite good spectrum for abscess kind of bacteria. They don't have amazing gram positive spectrum, But presumably they're a really good choice if you don't have a cell wall. Any other classes of drugs that we might use?
Would we use like what is clindamycin? Because that doesn't target cell wall, it
Yeah,
targets the
right.
ribosomes or something, right? Like
Yeah, exactly right. So that's a
I can't
really
remember what clindamycin group, like the
the
group is like
lincosamide.
linkosome idea.
Yeah. And then the other one is the one that we use with weird bacteria. What's the go-to for mycoplasma?
Rhodoxy.
Doxy. Yeah, exactly. Tetracyclines. So they're the sorts of if you're ever in that situation where you've seen a polyarthropathy secondary to a cat fat abscess, you'll know exactly how to treat it. But if you do actually see that, can you let me know? Because I've never ever seen that.
Yeah, I was going to say, have you actually seen polyarthropathy in a cat? Because I so far haven't come across or seen.
Yeah, no, I have seen a couple of cases in cats, almost always secondary to infectious etiology.
So
And not
cats infectious more likely then.
yeah, for sure. And because they get weird infections that are
Mm.
hard to detect, right? Like all of the mycoplasmal infections and Bartonella and
Mhm.
those
Can,
like viruses.
with those, can those bacteria be cultured that don't have the cell wall? How do
In
we prove?
specific conditions, they can be, but you can't just like submit a swab like you would for anything else. You have to let the lab know that you're looking for ill-formed bacteria and find some instructions.
So most of the time we won't know. Like we'll probably just treat and then not know that.
No, I reckon if you did like a diff quick and we're like, there's no bacteria in here, I'd be suspicious.
Okay.
Yeah. But yeah, practically, no, we're not going to know. We're probably just going to throw antibiotics at them until it responds to something. But maybe if a penicillin doesn't work, reach for one of those three
Mm.
that we talked about. Um, okay. So they're the direct infections. What sort of infections, systemic infections, do we see polyarthropathy secondary to?
Like endocarditis, maybe?
Good, excellent. Yeah.
'Cause that's like showering everywhere.
Yeah, for sure. Anything else?
Any fungal infection?
Yeah. Yeah, definitely. I would assume so.
Does
The only time I've like conscious of seeing that is in a shepherd with a disseminated aspergillosis.
Mm.
But yes, rare. But they've got so many other signs, like they've got raging disco and stuff like that as well.
Yeah. Yeah.
And
And
kidney.
then maybe skin, like really bad skin, so pyodermas, like deep, obviously not superficial.
Yeah. And what about, we're thinking very bacterial here. What other classes of infections might we see associated with polyarthropathy?
Not sure I understand. What do you mean by classes of infection?
Rather than bacterial. So we've sort of gone bacterial, fungal. What else?
Viral.
Viral, good, excellent. Yeah. So common in cats, I would say. Like we see polyarthropathy secondary to a viral infection. Not that common in dogs.
do you, do you reckon Iliki is going to start coming further down with climate change? And is that going to be a issue with polyarthritis? You're not.
Do you know what? I don't know how dependent Ehrlichia is on climate. So lepto, for sure, because it's in puddles. Like it loves wet environments. But Ehrlichia, there's outbreak of Ehrlichia in, not an outbreak, but there was reported cases in fighting dogs in Melbourne. Um, yeah, so I'm not sure.
I
I
feel like
think,
I feel like with the tick, like surely it will just be like a tick um distribution thing. I don't know. I feel
yeah.
like in the future we might see some more
More.
concerns.
Well, I think we're kind of losing control of it, aren't we? And people are getting dogs from because pet shop, the traditional pet shop acquisition of dog model is kind of harder now. People are getting rescue dogs, and those rescue organizations are sourcing the dogs from kind of far and wide because there's less barriers to transporting them. So, I mean, we've seen in Sydney cases of Ehrlichia from dogs that were just picked up from the Northern Territory and rehomed without necessarily even telling the new owners where they were rehomed from.
And is that an example that could present as polyarthritis?
Yeah, for sure. Rickettsial diseases are like the most common bacterial cause in other countries, but not in
Oh,
Australia.
I thought it was, yeah, gets you.
Yeah, because Ehrlichia is one of the rickettsial organisms, isn't it? I feel like I ask this every week. I always forget, but it's one of those
Yeah.
bacteria. Yeah.
Yeah.
So
And then you have your protozoal leishmania, which we don't have in Australia, so
yes,
we'll talk about it.
good. So protozoal infections. I did want someone to mention that. So systemic infections with protozoa, really common cause of arthropathy in other countries, not in Australia. The protozoa we have here, not so much. Although I have seen a dog that I'm sure had a polyarthropathy with neosporosis, but it also had a raging hepatitis, pneumonitis, pancreatitis, and amazing skin lesions, like necrotic skin lesions. That was where we got our diagnosis. Like the pathologist saw a neospora in a swab from a skin lesion.
Did it live?
It
Does the
did.
dog live?
It did. It did. It did.
Hmm.
Yeah. It had IMTP and it was on pred. And developed neosporosis secondary to its pred. And yeah, got through it, but it was rocky. It was a close call.
Hmm.
And what made you think that it had polyarthritis? Was it painful or did it?
The way it was moving more than anything else. I didn't end up tapping it just because there were so many different things that I wanted to do. It also was thrombocytopenic and like SIRSy, like really septic. We ended up just sampling the skin lesions. Yeah, I really wanted to biopsy the liver, but it wasn't a good idea. Okay, so we've covered protozoa, bacteria, including those weird bacteria, L-form and rickettsial organisms. We've covered fungi, covered viruses. What's one other systemic infection which might cause a polyarthropathy?
It's not going to be parasitic, surely.
It is, yeah.
Oh,
So heartworm.
Hmm.
Yeah, it's just that systemic inflammation, right? So any
true.
systemic, we could say any systemic infection could cause polyarthropathy, but it's those case reports that we've actually got. So if you've got increased antigen, increased heartworms, you're going to have increased antibody and you're going to have increased antigen antibody complexes forming. So there's actually in that paper, I believe that Pooja mentioned with that classification of polyarthritis, there's essentially a list this long of tests that you should do for infectious diseases before you call it an immune-mediated polyarthropathy. In Australia, we've got very few of those infections that we know about, which makes me think there's got to be some that we don't know about. Like we've got different ticks than they've got. We don't have Lyme's disease, but there's a Lyme-like disease recognized in humans. Therefore, there's probably a rickettsial organism or a similar organism that we don't know about. So I do think we have to have in the back of our minds when we're diagnosing a patient with immune-mediated or idiopathic polyarthropathy that there could easily be an infectious cause that we don't know about. And we just got to keep a close eye on them as we immunosuppress them and make sure that it's not emerging. But heartworm is one that I definitely would screen for in Australia. And certainly Ehrlichia and things now in Queensland and Northern Territory for sure, WA. Sorry. Um, hmm. Okay, so what about that's like our infectious list of infectious causes that can either infect the joint just directly or cause a reactive polyarthropathy. What about non-infectious causes?
So that's your prime. Oh, you mean like not primary, yeah?
Not primary yet. Yeah.
So drugs and vaccines can do it, maybe.
Great. Good. Yeah. Which drugs?
Isn't it? Like cefalexin has been
Yeah.
um, implicated.
Most of the antibiotics actually.
Yeah.
TMS is the big one.
TMS.
TMS. Yeah.
Yeah. Vaccines.
Vaccines cause a spike in rheumatoid factor,
Hmm.
but I didn't see that they were actually associated with vaccine with polyarthropathy. I wouldn't be surprised at all, but I'm not sure if it's been proven. What about neoplasia that might cause a reactive polyarthropathy? Has anyone heard of that?
Yeah, like that's the type 4, right? So,
Yeah.
but like what sort of tumors you mean?
Yeah. Yeah.
Carcinomas?
Good. That's the most common for sure. So typically either mammary, tonsillar, pancreatic, or renal. And in cats, it's kind of usually infectious, rarely immune mediated, or neoplastic if you're seeing polyarthropathy, much more common in cats. Okay, so say we've ruled out all of those underlying causes of polyarthropathy, and we're thinking, okay, I think this is a primary or a immune-mediated idiopathic polyarthropathy. How are we going to classify that? What testing do we want to do to, now that we've done all our infectious disease testing, we've done our joint tap and documented there's inflammation in multiple joints?
Have you done X-rays already? Like,
No, we haven't. That's what I want. Yeah, thanks. And what are we looking for on the X-rays?
whether there's, I guess, radiographic change, so erosive, non-erosive.
Yes, excellent. Have you ever seen an erosive polyarthropathy?
The one case of a polyarthropathy I saw, I'm pretty sure was erosive, but I can't
Yeah.
really remember.
Yeah, the erosive ones are actually quite rare. And they present similarly. I'm really sorry, I'm gonna cough again. Um, they definitely have similar presentation, but the ones that I've seen, all of their joints are collapsed.
I feel like the one I saw had like really swollen joints, and like it was a Great Dane, and
Uh,
it what do you mean by collapsed? As in it can't hold itself up, or the actual joint is?
the carpi will be really flat, like hyperextended.
Yeah,
The
so
toes get really flat.
the tarsi of that Great Dane were like really dropped and low, but I
Oh,
couldn't tell whether it was just because of pain, and so I was trying to get lower, or
yeah, yeah, interesting. Yeah, so the erosive form essentially is like rheumatoid arthritis. So that's where you actually get destruction of the articular cartilage and lytic lesions in the bone associated with it. I've seen a few of those, and I've missed the lytic lesions in every single one. Like I've looked at a lot of X-rays of like non-erosive forms. So I would just say these are the cases that I would just send it to a radiologist and let them do their reconstructions and fancy changes in um, settings and stuff like that that let them detect them, because often they're in really complex joints, like the hock and the carpi are really complex joints. And yeah, I've missed, like, the radiologist is pointing at it and I'm like, like I'm not sure.
But isn't it that with erosive, it's with time the erosion happens. So you can actually first time point, you may not necessarily even see it. It's repeat because the response to, they don't respond too well to your immunosuppressants. So then
No,
if the response is not good, then take re-X-ray them at some stage and re-radiograph them.
that's a really good point, because you quite often do have radiographed these patients and it's not until their responses, and then you go, oh, well, I've already radiographed them, I've ruled out erosive form, but actually it might have been kind of pre-clinically detectable.
at the same time, though, I feel like a lot of people, especially with lameness, kind of just leave their pets and like, oh, it'll get better, and so they wait longer than with if the animal's systemically sick.
Yeah. So all of the erosive form ones that I've been referred came from the surgeons, and they were referred to the surgeons for correction of a carpal hyperextension, and assumed that they had like injured or had some sort of endocrinopathy or something like that that predisposed to that, rather than it being an erosive polyarthritis. So they weren't even necessarily lame, or they obviously were so sore, but because it's bilateral, it's not necessarily lameness.
Aren't these guys a bit off. Like that's how you differentiate from musculoskeletal problem, because a musculoskeletal problem typically animal will just be lame, whereas with arthropathy there'll be some, like if you really dig the history, there'll be some thing to indicate that this is more than just a musculoskeletal, because like they are a bit off sick, waxing and waning something.
And I think an example was that Great Dane had gastrointestinal signs, but I
Hmm.
think the owner just thought, oh well, it's always had a sensitive stomach.
Yes.
Um, and then
Owners
they,
can write off weirdness till the cows come home.
Hmm.
Yeah, ever since I've sat my memberships, every most animals have chronic enteropathy.
Yeah, yeah. Most.
Remember, like it was always like that question, when you do your annual health check or vaccinations, like any vomiting or diarrhea, and like I feel like most of the people like, oh yeah, I'm like, how long has this been going on for?
Yeah, they don't seem to mind. And then you get those like clients who are like 2 a.m. like, my dog's just vomited. I'm like, okay, let's just see what happens. Oh dear.
Both ways.
Both ways, exactly. Okay, so the non-erosive form is much more common. Can we divide non-erosive immune-mediated polyarthropathy into other categories?
Do you mean like breed? Because I think there are some breeds that are predisposed, and even in cats, there's something specific which I can't now recall, but
Yeah,
there's something about cats as well.
that's in the erosive category.
Yeah, in the erosive category.
I'm gonna open the textbook. So let's talk about non-erosive. So there's breed specific. So Sharpei's and Akitas get
Mm.
genetic non-erosive forms of polyarthropathy. And then idiopathic is our main one.
Hmm.
It's probably a systemic inflammatory process or something else going on, but we can't find it. So we're going to treat it as an immune mediated. And then the other category is actually systemic lupus erythematosus. So those dogs we're sort of saying, oh, they're just off and stuff like that. There's sort of quite specific markers that we should look for, and we'll jump to the systemic lupus chapter and go through that kind of diagnostic criteria in a sec. So when there's more than just the joints affected, it's definitely worth kind of doing a little bit of a wider screen. So what about the erosive form? Are there any extra tests you would like to do on a dog that had erosive changes on their radiographs?
Test their rheumatoid factor.
Good. Yeah. What's the value in that test?
I'm under the impression not particularly great.
Not particularly great. Do you know what rheumatoid factor is?
Mm, not really.
It's actually an antibody directed against IgG. It's an antibody. Yeah,
Hmm.
which is weird. Um, so I think it then disrupts the normal clearance of IgG from the system. So when it's marked, it doesn't get cleared or something. So you end up with more antibody and therefore more deposition in the joints. But it's not, I don't really understand how it then leads to erosive polyarthropathy. But only about 70% of dogs are positive for that. So you might have a clear-cut erosive rheumatoid arthritis and it not be positive for rheumatoid factor. And that's true for humans as well with rheumatoid arthritis. Rheumatoid factor is not a very reliable tool. Um, so how do we treat these guys?
Suppress them with pred if it's primary. And I had a case of that was, I thought, type 3 because it had GIT signs. The thing is, I just sat on it with the GIT signs, and once that cleared, the lameness and the stiffness in the joints also cleared. So I didn't really suppress that dog.
Yeah, interesting. Um, so that we kind of skipped over diagnosis. We talked about radiographs and stuff. Do you and infectious disease screening, would you guys routinely do abdominal imaging, thoracic imaging, or echo in these patients?
I always offer clients imaging, at least RADS and thoracic RADS and abdo ultrasound. not so much echo. But at least the basic, if not abdominal ultrasound, then at least because abdominal ultrasound, like the diagnostic, I am not particular. I can do a basic one, but not really. I don't claim myself to do a diagnostic one. At least do rads then, abdo rads, just to look for something really obvious.
Yeah, neoplastic wise.
Yeah.
The only reason I mentioned that, I probably wouldn't have pushed that hard for additional imaging, but a paper came out last year which was very enlightening. So they looked at, it was like 90 dogs with rheumatoid arthritis who had abdominal imaging, echo, and thoracic radiographs. Thoracic radiographs changed the outcome in 0 of those 90. So they said, don't focus on that, like if you've got budget. Abdominal ultrasound changed the outcome in like 40% or something like that. And of the dogs that got echoes, they didn't all get echoes. It was like, I think it was like 17% or something. So presumably these are the dogs with murmurs, and like there was a reason they got an echo, but a lot of them had endocarditis. So overall, addition of abdominal ultrasound and echo to the diagnostic workup changed the outcome and direction of treatment in 25% of cases.
Oh, are we saying infectious endocarditis?
Yeah, exactly. Yeah.
But wouldn't you have picked that up through your other diagnostic testing?
Probably not. Yeah, so infective endocarditis is often just a skin bacteria or something like that. So it's not something we would have specifically tested for. We don't routinely do blood cultures in these guys, and blood cultures are notoriously falsely negative in endocarditis often. Echo is not actually a great tool for endocarditis, so it's definitely reported. So they did a study on dogs that would just died of all causes, and they necropsied all of their hearts, huge numbers, and like 4 point something% of normal dogs had endocarditis at the time of their death. Like really underreported from the testing. It's really hard to diagnose, and often they can have endocarditis and be completely clinically normal older dogs with just going downhill and stuff like that. So yeah, detecting endocarditis, I reckon, is one of the harder things, or confirming it is one of the harder things that we have to do. But it could just be a staph, strep, E. coli, any of those bacteria that you can't really test for.
Then I thought endocarditis makes you really sick, and then there isn't like the survival really poor with endocarditis, like it's like 84 days or something like that.
So they're the ones that we can detect.
Okay.
So if we think about the different kind of levels of pathogenicity within all of the different bacteria, those like mycoplasmas and stuff, Bartonella, can just cause these really subtle signs. No pyrexia at any point along the way because they don't have endotoxin in their wall, or they're not pyrogenic particularly. They don't cause a huge inflammatory reaction, so the clinical signs aren't that notable. So particularly gram positives and those sort of weird bacteria without the cell walls and stuff, they're not very inflammatory, and there's not a lot of clinical signs.
Wonder if since treatment is so prolonged, do you just do repeat blood cultures at revisits just to see if you can pick up
Better
anything
do
throughout their time?
antibiotics. Yeah. What about, so I can't remember what the percentage is, but it's absolutely huge, the number of bacteria that we can't diagnose on culture.
Mm.
There's so many. And particularly those ones that are not causing really overt clinical signs. Like we know about E. coli because it tells you it's there. Like you've got a fever straight away. Like, and so therefore we've done a lot of research, and those cases are really clear cut. Those dogs are pyrexic. Whereas these weird bacteria don't culture in labs. We've not got a lot of research on them because we have only developed genetic tools to detect them recently. And there's going to be better screening now that we do have those PCR tools available, better screening for those infections on blood submitted, but culture is not going to find them. Watch this space though. Jeff, I keep thinking you're about to say something. I'm not cutting you off, am I? Okay. Okay. So now that we've talked about diagnosis, treatment. How do we treat them? Fred?
Wait, can I ask? So does that mean that you now, since that paper, you would now recommend abdo ultrasound and echo for? Okay.
Yeah. And I might screen my echo candidates. Like I'd probably offer it to everyone, but also just say, look, we may or may not see anything. But then, so like we see, because I do echo so many dogs, there's so often that I'm like, I can't hear a murmur, but I can see blood leaking. And if blood's leaking at low velocity, so if it's like pulmonic valve or tricuspid valve, or if it's leaking in diastole, our ears just aren't very good at picking that up. So aortic valve as well. So we're really good at hearing mitral murmurs because we hear them all the time and we practice. But those other murmurs, like quite often, I'm like, I missed that completely. Like I see it on the echo, but I missed it listening. So I don't think it's the wrong thing to just recommend echo in all of these guys, just to screen for endocarditis.
And if you do find something, how are you going to know that's significant?
In the heart,
Yes. Yeah, because
um,
so many animals have non-clinical endocarditis.
yeah. And the tricky thing, like if you see endocardiosis, it looks very similar to endocarditis on an echo, like a thickening of the valve, vegetative lesions and stuff. I think probably if it was on a valve that was weird, like we don't often see, like the pulmonic valve looks like a piece of paper, like it's so thin. If I saw a knobble on a pulmonic valve, I'd be like, that's really significant. Same thing with the aortic valve. Actually, I've seen aortic endocarditis quite often, and the valves, instead of looking like this, are all curled up and they're bright, like they're fibrotic looking, and they often leak because they've lost their like nice apposition. So we've not only got like turbulence on the way through, but we've also got insufficiency. So
It's a common area though, pulmonic, sorry, not pulmonic, aortic for endocarditis. Isn't that a common valve?
it's the most common in humans for sure.
Mitral.
Yeah, mitral is the most common in dogs.
And then aortic is the
Yes.
second one.
Yeah, exactly. Yeah. Um, okay. How do we treat it?
Good old Pred.
Red, exactly. So there's no evidence of any other agents being superior or adding in other agents being superior, but obviously there's some dog breeds that don't tolerate pred very well. And so I would add a second agent as a pred sparing thing. There's a study that says adding leflunomide is not effective, but
Yeah.
adding mycophenolate might improve outcomes. What's the prognosis? Like what sort of, let's say we're just talking about the idiopathic ones because they're the ones that we're immunosuppressing, right? Or immune mediated ones. If you've got an erosive form or a non-erosive form, how would you manage the client's expectations of outcome?
So non-erosive with primary, the response is pretty good and quick.
Yeah.
You do need to keep them on a bit longer. You don't just like sort of stop it.
And they do
You can
often,
taper it down and stop, like taper it down and like keep it. And then I don't know the exact percent of relapse, but there is a fair percent that will relapse.
yeah.
And then there's about a few, again, I don't know, but it's a very minuscule that fail to respond.
Mhm.
And these are the ones I would then screen for non-erosive. Sorry, erosive.
Yes, yeah, exactly. Good. So really, if they're relapsing, I would say let's free radiograph. But erosive has quite a poor prognosis. It's a very progressive disease. And often, as I was saying, the ones that I've seen are so far gone, like they've got so much degeneration in their joints that they're already kind of almost terminal from a kind of mobility perspective. Several of them we have stabilized the carpi surgically in some, but there are quite good braces now as well. So if the dogs will tolerate external fixation as far as like wearing a brace, not like an X fix, then that's a nice option sometimes just to try and get on top of it. But the damage is already done by the time you're immunosuppressing these guys often.
Mm.
Okay. Now, systemic lupus was one of our things we should be looking for with polyarthropathy. What other signs might you see with systemic lupus?
So isn't systemic lupus, firstly, you have to have multiple body systems involved, like it's not just one body system. There's a criteria, your major and minor
Good.
criteria to diagnose it.
Yeah. What's a major criteria?
Mm, I think the major is having, I can't remember now exactly, but then at least is it 3 or 2 body systems involved, and then you have to do the ANA has to be positive.
Exactly. So 2 and an ANA. The ANA has to be positive, so that's not a major criteria. But what other body systems are we looking at? What
Renal is a big one. Renal
what do we see?
glomerular nephropathy.
Good. Yeah, so they're often not azotemic actually.
Mm.
How do they present?
So proteinuria, maybe I should say.
Great. So you kind of got to look for it. It's not something that we'd notice really, and it's not something that comes with clinical signs. We might see gradual progression of the creatinine, but often they're not azotemic. That they've got quite a high level of proteinuria. So that's really
Thyroid platelets and red blood cells.
great. Yeah, absolutely. Thyroid. Thyroid's hard because they can have thyroid antibodies, but that can cause hyper or hypothyroidism. So thyroid's hard to associate with lupus. They commonly do have antithyroid antibodies. But the red cells and platelets are really common. This rumbling IMHA, IMTP. Any other systems?
Skin, like your skin will have multiple like depigmentation, erosions, ulcerations, all these sort of things, crusting.
Yes. Where? What's our distribution of lesions?
Oh, distribution, not sure. Was it okay, I'm just saying, is it oral or mucocutaneous? Would it be?
Good. Mucocutaneous, yeah, predominantly. They can have buccal. Is that how you say?
Yeah.
Buccal. What is it?
Potato, same thing.
Say
In the
buckle.
mouth.
Yeah. Apparently like quite pruritic buccal lesions can be reported. Ear tips, the crusty ear tips, the corners of the mouth, just around the edges of the anus, and the paw pads, quite common regions that we get lesions. In humans, there's a really distinctive butterfly-shaped rash that goes over their nose, and that ties back to the pathophysiology of lupus. Does anybody know, like it's obviously like an autoimmune disease, but what is the body targeting, or what's the self antigen? Or what's the pathophysiology is my question. It's a trick question. We don't know.
Yeah, I was like, it's there.
They don't fully understand it. And there's a few different kind of proposed theories, but essentially it's dysregulation of a lot of different elements of the immune system. So we know that interferon 1 is activated inappropriately, which then causes activation of multiple B cells and inappropriate differentiation and loss of like that self-tolerance. So then the B cells then tell the plasma cells to produce or evolve into plasma cells producing autoantibodies against a lot of different antigens in the body. But it's like a immune system dysfunction right at that cytokine level. So the reason why this butterfly-shaped rash coincides with the pathophysiology is that interferon 1, IFN1, is activated by UV light in these patients. So I was really interested because our patients have fur. most of their skin doesn't coincide with like see the sun. But you might get lesions in sun exposed areas, like if you've got a whippet or something that's got like a bald chest, you might see and likes to sunbake. And Edinger did actually say keep them out of direct sunlight, because as soon as that interferon 1 is activated, it then goes into systemic circulation and upregulates the B cell activity. But yes, because this is a very sun exposed area.
That interests me, what you say about the ears. And of course, particularly in rural dogs, we used to see what we thought was fly worry
Yeah.
on the ears, and it was always symmetrical. And to me, that seemed very odd that it would be fly worry symmetrically.
Yeah.
Now I'm just wondering whether there were lupus cases that the flies got into as a secondary invader. What do you think?
Could easily be. And lupus or vasculitis, I would say. So vasculitis is also kind of on my list of things to talk about, because lupus, you could have vasculitis with lupus, but vasculitis, we often see the tip of the ears getting crusty. So then vasculitis could be, particularly in rural dogs, secondary to infectious causes or autoimmune causes, for sure. Did you see a lot of heartworm out there, Jeff?
No, most of the heartworm I saw was when I was in Riverston,
Oh, right.
in the Hawkesbury area.
Yeah. Okay.
I did see some in Canberra, believe it or not.
Oh, right.
Around the Piala, that came from either around the Woden Golf Course or around the Pialago Marshes.
Interesting.
Now that's back in the 70s.
Yeah, I wonder what the rate is now.
I saw heartworm in a dog in Queanbeyan that was housed with a dog that had come down from Darwin after Cyclone Tracy.
Oh, right. So yeah, right. So they're transmitted, do you think? Yeah, right.
Obviously a very busy mosquito.
I was going to say that's bad luck, actually.
With the skin lesions then, because if these are oral mucocutaneous junctions and things like that, the other big differential would be epitheliotropic lymphoma.
Yeah, or pemphigus or other kind of dermatologic kind of immune-mediated diseases, for sure. Yeah, so these guys need biopsies. Yeah, so if you've got skin or mucocutaneous lesions, definitely biopsy, because there's so many different subcategories of inflammatory diseases that could cause that pattern of inflammation. And often that kind of comes back as non-specific vasculitis, and you sort of go, okay, that doesn't help me at all to subclassify, but actually what it's helped you rule out is really important. And you've met your criteria, you've demonstrated vasculitis, you've demonstrated that you've got like polyarthropathy and vasculitis going on, and that's your two body systems, and you've got a positive ANA, and you've got your diagnosis.
How often do you get a positive ANA? Well, I thought it's not particularly high. Like you do it, but it's not. But I'm not sure because I've never seen.
I think that's because lupus is rare, right? Yeah. So I've definitely seen positive ANAs, but I run it in cases that I'm like, it's not going to be lupus, or no, it'll be interesting if it's lupus, but I'm actually pretty sure it's just IMHA with secondary antibody antigen complex or something.
And then, so the main thing would be if you have lupus in your head, you should run it before you start the pred, right? Like pull before, do the ANA before, not after you've done some therapy and then now you're thinking lupus.
Exactly right. Yeah.
If you're biopsying these lesions, I know with vasculitis, do you find that the biopsy area makes it worse, like extends the lesion because of the
Usually,
inflammation and stuff that you're causing?
no, I mean the skin biopsy punches are so like non-inflammatory. Yeah, I don't think so. I think it's pretty well tolerated. Obviously, there's damaged skin. It's not going to heal as well as other skin would, but it's also a very superficial wound that I'm not that worried about. And presumably, the biopsy is going to facilitate the therapy that's going to get the skin to heal in the time frame that you're wanting it to heal. So I think it definitely, I wouldn't put it off in these guys because it is minimally invasive. We often just do it under Domitor. In fact, that's preferred to
Yeah.
most of the systemic GAs.
Yep.
Pooja just mentioned a basic principle of medicine: always get all your samples before you treat with anything.
Yeah.
Otherwise, what you're sampling is your modification of the native disease.
I love that theory, but I also work with clients and they say, can't I just have the drugs? And it's not until the drugs fail that they come back and go, oh, right, I'll do the tests.
But how long can you collect and keep it? Like, don't send it, but at least have the sample. So if later down that, but I just don't know how long you can just sort of store it in a way. Like, I don't know that.
Yeah, and it depends what you're looking for. Like if you're
Yeah.
looking for a culture, then you kind of got to send
You
it.
can't really, yeah.
Yeah, and then it's the sampling that it should be the sampling that's the costly part.
Mm.
Like it's our expertise taking those samples, and that's what the clients have declined often. I can be very persuasive, but
Yeah.
I
I'm,
still
I'm pretty sure though, and this is something that has been messing with me because I went to a pathology course earlier this year, and saying that with cultures, it probably might be better to freeze them than to keep them in the fridge,
Mm.
and that you're more likely to get a yield if you freeze, in representative sample if you freeze in a -80. Which I was like, how does that work? And I haven't been able to find a source for what they said, but I definitely heard it and wrote it in my notes when they said that, and I've got a table for it, but I can't find the resources that show that that's the best way to do it.
And realistically, like -80 freezers are research labs only.
Yeah, I was like, where do you get that?
Well,
Uh,
-20 is still better than fridge,
is it? Yeah, right. Okay.
but -80 is best.
Yeah.
But I have to find a resource because unless it's just anecdotal from all the pathologists that just do it.
Yeah.
But
No, for what time frame? Like if I can get it to the lab in 24 hours, do I want to freeze it while I wait for them to come and get it shipped on dry ice? Or do I go, no, that's only if I need a culture in like a week's time?
well, I guess it depends on the pathogen too. And I think that's what they were trying to say, that obviously it
You
doesn't
have to
fall.
know what you've got before you decide how
Yeah,
to fix it.
Or
have to
have a suspicion of, oh yeah, because otherwise every urine is going in the freezer.
Yeah, that's right. Yeah, interesting.
I'll have to try and find something for you.
Yeah, that's very interesting. Oh yeah, why don't they die in the freezer?
Well, I wonder if the freezing process doesn't pop bacteria and that their cell wall must be.
Well, there goes all of the like, all the raw food. They like we snap freeze and that kills most pathogens.
Well, I think that's the thing. It doesn't kill most. That's why, like, you can freeze chicken, but you would still be
Cook
mindful
it.
how you use it.
Yeah, that's true.
And
Yeah,
that you could use it still has a use by date if you do put it in a freezer.
yeah, true.
Mm. Anyway.
Okay. Last thing I want to show. So that's all I wanted to talk about with lupus. It's so rare. I don't want to spend too much time on it. But vasculitis, which we kind of have touched on. I want you guys to have a little like, if you've got a patient that you've got that ear tip crusting and you've got a bit of crusting in the corner of your mouth and they might be a little bit pyrexic and they might have a few little skin lesions and stuff. And you're thinking, oh, it could be a vasculitis. I want you to think about the different etiologies that might be causing that. So they're very similar to everything else we've talked about in the like joints and like infectious causes or immune-mediated causes. It's all the same. But there are some specific infections that actually infect the vessel walls. Can anyone think of what they might be?
Heartworm is one, isn't it?
Yeah, well, so heartworm traumatize the endothelial cells, but they don't actually get in the endothelial. Yeah. So Bartonella is a big one.
Yeah.
I think lepto does it. Like its first phase of replication gets into the endothelial cells. And then the one that's the answer to everything that we don't really have in Australia.
Oh, it's some fungal, is it?
No, it's just rickettsial diseases.
Okay.
Just always say rickettsial diseases. Anything vasculitis-y, like jointy. So they're the kind of infectious causes. And then what about immune-mediated causes? Oh, infectious causes. What's the most... Oh, no. Okay. Sorry. Similar to the joints. We've got local infection, and then we've got distant infection with reactive vasculitis. So that's where the deposition of the antibody-antigen complexes like get stuck in the very small vessels. Where are the very small vessels? Joints. That's why there's overlap in these diseases.
Kidneys,
Kidneys, very good. Glomerulus, yeah, excellent.
skin,
Skin, excellent. Periphery, so pads, paw pads, same kind of distribution of lesions as we see with the SLE.
Joints, I suppose.
Joints, yeah, and eyes. This other one. There's often a uveitis associated with these. So what is the most common infectious cause of reactive vasculitis in cats?
FIP.
VIP. Yes, exactly right. So where we kind of thought about those like extremity kind of manifestations of these antibody-antigen complex disorders, now I can think about the more like big body cavity ones, like an effusion, a small volume effusion or a large volume effusion might be an alert for vasculitis if you're not seeing any other reason for that. There's no hydrostatic congestion or anything. So FIP causes disease by causing vasculitis and leaky vessels. All right. The only other thing with vasculitis is that we might get petechiae as well, because we get disruption of those vessel walls and then leaking of blood through there, which is not typical for SLE. All right, there you go.
Thank you, Anna.
Thanks,
thanks for
guys.
powering
No worries.
through.
Bye.
Oh, thanks, Anna.
No worries. It's nice to see you, Jeff.
Yeah,
Bye.
back from the wandering. I'm on a work break at the moment.
Ah, that's nice. Good to hear. I'll see you soon.
Yeah.
See ya.
Bye.